All right, the next step in our respiratory presentation, we're going to be talking about thoracic trauma. So this is a lot of different problems that all kind of have a similar way that we work with these types of patients. Again, down in the description for this video, I'll put the links to all the videos, but there are some good ones in here that can kind of keep it a little bit fun. So this one here, as an introduction, it's a bunch of people just kind of getting pummeled in that old TV show Wipeout, which is kind of a good way to tee up thoracic problems and trauma. So the first one we're looking for is rib fractures. Fairly basic. Patho, you got a bone, you break it, specifically ribs. Good with that? Wonderful. Etiology, the way it happens, usually people get rib fractures from trauma. So go bang. Yeah. So a couple different things we need to pay attention to with rib fractures. One is it a single rib fracture, like I've had, not comfortable, you crash when you're skiing, fall on some stuff, break a rib, tough day already. Others are if patients have like blunt trauma to their chest, like a steering wheel collision, things like that, we can have multiple contiguous rib fractures. This can lead to some of those really odd assessment patterns, things like flail chest or paradoxical chest movements, which we're going to talk about here in a little bit. But you can kind of see what paradoxical chest movements are going to be like when a patient breathes in and they have multiple rib fractures, all sequential. When they breathe in, it's going to cause a caving of their chest. When they breathe out, there's going to be a bulging of their chest because their rib cage is no longer a stable protective structure for their heart and their lungs. So we do need to watch out for that, especially with our blunt force trauma type of injuries. So the big symptoms we're looking for with our rib fractures and with a lot of our other chest trauma type things is first and foremost pain. These patients are going to be in quite a bit of pain. They just went through some kind of traumatic experience, which is the whole reason they've got these fractures. So we're going to use things like NSAIDs, opiates, all the kind of pain medications, whatever needs to be done to control their pain appropriately. Shallow breathing is another big one. So patients who get rib fractures, they don't tend to take full deep breaths because of the pain that goes along with expanding and contracting the rib cage. So as the rib cage expands, it kind of pulls on that fracture, which can cause a lot of pain. One of the complications we tend to see for patients with rib fractures, either single or multiple, is because of this shallow breathing, they can develop atelectasis, which is the collapse of that alveoli. Untreated atelectasis can easily progress to a pneumonia. So we do want to be really, really cognizant of that. A big thing that we're always focused on for patients with shallow breathing presentation is we want to get them to breathe like a normal person, right? We're always pushing our abnormal patients to just be like a normal person. So our goal is get them to breathe. The tools we have to do that, nurse's favorite tool, our incentive spirometer. It's gonna suck for these patients. It's gonna cause quite a bit of pain for them, but it's super important that we keep their lungs fully inflated so that they can do appropriate ventilation and respiration. So they can move air in and out appropriately, and they can perform gas exchange appropriately. The other thing we want to teach them is coughing and deep breathing. So those kind of forced coughs along with some deep breathing. It can be helpful to teach your patient to do splinting when they have rib fractures, which is kind of when they hug a pillow when they do that coughing and deep breathing kind of motion. Paradoxical chest movement is that abnormal movement of the chest that presents when patients have multiple rib fractures on one side. So all the rib fractures on one side, it's that movement in and out of the chest unilaterally. So we're not seeing the same type of movement on both sides of the chest. It's part of why when you guys learned your head to toe exam, it's like you get down to the foot of the bed and you're looking for symmetrical chest rise with respiration. This is what we're looking for. Here's a link to 2 videos of patients with paradoxical chest movement, and it's freaky. You guys are gonna see it. It is very, very abnormal and a little bit awkward to see a patient's chest moving in that very paradoxical way. Flail chest is kind of the worst version of these paradoxical chest movements. Flail chest happens when patients have multiple rib fractures on both sides of the thorax. So they've got multiple fractures, both sides. The problem here is that it makes it very, very difficult, if not impossible, for patients to expand their rib cage, pulling air into their lungs. When their muscles try to expand their rib cage, because of those fractures, the ribs don't actually expand, making that negative pressure environment in the thorax, causing ventilation to occur. So these patients can have some respiratory failure as a result of severe bilateral rib fractures. Are patients like this dude who hits a steering wheel like kind of head on or has like front on their chest kind of trauma, very, very high risk for that flail chest presentation. So we always want to be very, very careful of our respiratory exam whenever we're dealing with fractures around the ribs. This is what atelectasis looks like. So these are normal, healthy alveoli in a patient's lungs. Nice and open. Here's where gas exchange happens in the capillaries in the lungs. All good right there. This is atelectasis. So all these alveoli have collapsed in on themselves, meaning that gas exchange is not happening as effectively because we're not getting air into all these alveoli because they're collapsed. So the hallmark symptom that we appreciate when we assess patients who we have atelectasis is we're listening for crackles. What crackles is it's the sound that these alveoli make when they go from compressed or deflated to inflated. And then when the patient breathes out, they collapse again. So it sounds like that popping that you get in cereal when you pour milk on it, that kind of light popping sound, or like if you get a handful of sand and kind of rub it around your fingers, it's that kind of crackly poppy sound. But that is what atelectasis looks like in a patient's lung. We always want to use our tools to get our patient's lungs back inflated so they can respirate appropriately. And this is how we do that. Our IS is our life-saving tool that patients hate doing because they have to do it a lot. But if our patient has atelectasis, if their lungs are all compressed like this, their alveoli are all compressed like this, we can fix this problem in one shift. They just need to use this thing. And how often are they supposed to use this thing? 15 times per hour. It's tough for patients to keep track of that. In the inpatient setting, what I tell patients is every time a commercial comes on the TV, go ahead and use this thing once. Because one thing we can guarantee is they're all watching TV and 90% of them are watching the Food Network. So whenever the commercial comes on, just use the spirometer once and they're definitely going to hit that 15 per hour goal. So if a patient has rib fractures, the medical diagnosis component is going to be how do we prove that that is the thing going on with their patient. So chest x-ray. We want to visualize the rib fractures. We want to see exactly where on their chest wall they have fractures, whether it's one side, both sides, one rib, multiple ribs, ruling out those kind of unstable chest wall presentations, either the paradoxical chest wall movements or a flail chest. We want to visualize what that is. For patients with the flail chest kind of presentation, that very severe bilateral paradoxical chest movement, these patients are going to have an increased work of breathing. They're going to have respiratory distress, and the more bilateral rib fractures they have, the much more severe this is going to get. The big component of this is then we need to look out for complications. Complications can include things like a collapsed lung or other problems of accumulation around the lung surface. So, life lesson, one of the big deals in nursing is always looking out for complications. So if our patient is one way when we first assess them because of their rib fractures, if an hour or two later they've got some new symptoms, that's weird. We need to follow up on that. We need to assess what those changes are and really show exactly what the change is. So one of the big problems that can occur secondary to either trauma or for medical reasons is patients can develop what's called a pleural effusion. So pleural effusions are accumulations of fluid outside the lung, but inside the lung bag. Because the way the body works, you guys remember from A&P, the body likes to put things in bags. Puts the heart in a bag, puts the lungs in a bag, puts the guts in a bag, puts muscles in a bag. It just likes to have things in bags. So the pleura is what we call the lung bag. And there should always be a little bit of fluid between the lung and the pleura. It's normal. There should be about 5 to 15 mils in that pleural space, just to provide lubrication so that as the lungs expand and contract, they don't rub up against the bag that they're in. If there's not that fluid and they do rub, 3 guesses what we call that because we're super creative in healthcare. We call that a pleural rub. And it sounds like if you get your fingers wet and kind of rub them next to your ear, that's the sound of pleural rub. It sounds like pieces of rubber kind of rubbing together. But patients can accumulate a lot of different fluid or a lot of air in that space as a result of medical problems or traumatic problems. They can get up to 2 to 3 liters around their lungs, which is really, really bad. And that will cause a lot of those respiratory assessment problems that go along with difficulty breathing. Because as that lung starts to have more pressure outside than inside, because inside's just air, so any fluid out here is more dense, it's going to compress it a little bit. The patient's not going to be able to breathe as well. So we do always want to look out for this. Pleural effusions come in a lot of different flavors. And one of the main ways we can tell what kind of effusion they have is what kind of stuff is coming out of it, right? So the type of fluid that comes out is really going to tell us what kind of etiology or what type of problem is causing the fluid to accumulate in the first place. We've got our medical reasons and we have our trauma reasons that patients can develop an effusion or a collection of stuff in the lung bag. So let's take a look at the medical ones real quick. So looking at our different colors to tell us what kind of different problems we have, we've got our transudative pleural effusions, which are usually a result of kind of metabolic processes of volume overload. So a lot of our diagnoses like congestive heart failure, ascites, things where patients are retaining a lot of fluid in their body that's not able to be managed by their circulatory system, this is a big risk. A lot of our fluid color that's going to come out of that is going to be like our serous drainage. So it's going to be clear to slightly opaque, but there's not going to be a lot of stuff going on in there. It's going to look fairly good, especially it's going to look really good compared to all the other things. Then there's our exudative pleural effusions. These tend to happen with like invasions into that pleural space. So things like a cancer, which is going to have invading tissues going into that pleural space. Viral infection, so we have a pathogen that's invading into that space. Same thing with like pneumonia. So that's a bacteria that's invading into that space. So exudates, think back to the fluids that we learn about. So our liquid exudates, serous drainage, sanguineous drainage, serosanguineous drainage, and pus. So exudates means that there's kind of stuff being produced. So this type of fluid, it's not going to be like our strict serous type fluid where it's kind of clear to opaque. There's going to be kind of chunks in here. It's going to be kind of milky, chunky, like lots of little floaters in there. It's kind of getting a little gnarly. But that's what our exudative pleural effusions are going to look like. And then the last ones are our empyemas. These are abnormal collections of pus in that pleural space. So there's pus all around the lung bag. And there can be like liters of pus in the lung bag outside the lung. It's gross. And we know that pus equals infection. Yep. So this can be bacterial, thoracic surgeries. So any kind of surgical site infection in that pleura is going to produce our purulent, pussy drainage. And that's called an empyema. These are gross. They're really gnarly. Usually patients don't get like a couple liters of pus, but they do get a fair bit in there, and it's gross. So these ones tend to be our traumatic reasons that patients get effusions. We call them slightly different names based on what's in there. So patients can develop a hemothorax, hemo meaning blood, thorax in the thorax. This is where like sanguineous drainage accumulates in that pleural space. So these are things like traumatic injury. Hemothoraxes tend to be more blunt trauma, but can also be caused by sharp trauma. Blunt trauma meaning like getting hit by something that's blunt. So sometimes the easiest way to think about this is to contrast it with sharp trauma. Sharp trauma is getting like stabbed in the chest, so something sharp. Also clotting disorders, particularly disorders of bleeding. So patients with clotting factor disorders who are on, or patients who are on medications that promote bleeding, we always want to look out for those hemothoraxes. And the color of drainage, hemo is blood. This is our sanguineous drainage. These patients are bleeding into that pleural space. Then there's our hemopneumothorax. So hemo, blood, pneumo, air, thorax, into the thorax. So this is a mix of blood and air getting into that pleural space, into the thoracic cavity. This is usually caused by traumatic injury of both blunt and sharp trauma. So something has had to puncture the chest wall, puncture the chest wall so that both air is entering into the chest, and from the trauma, there's also bleeding going on in there as well. It can be from clotting disorders, but most of the time if you're seeing a hemopneumo, it's because of this both blunt and sharp trauma. So these are like your big car accidents or big accidents of some kind tend to develop these kinds of problems. So we're going to see a mix of blood and air in the chest wall cavity. And then our pneumothorax, save the best for last. So this is air accumulating in that pleural space. These can be caused for a couple different reasons. One is what's called a bleb, which is kind of a fun thing to say. But blebs are kind of funny. They're particularly common in tall, thin-framed Caucasian women. Tend to have a higher prevalence of bleb formation. I don't know why, it's just kind of a thing. But what they are is on the surface of the lung tissue, there can almost get like it's almost like a little zit that can rupture, causing air to slowly leak into that pleural space. So we want to watch out for that. But the most common reason patients develop a pneumothorax really is that sharp trauma. So some kind of stab or puncture wound into the chest. And the collection that we're going to see is not a fluid collection because of pneumothorax. This is going to be a collection of air. Pneumothoraxes can exist in a few different kind of flavors, and we kind of keep them as a separate category because pneumothoraxes are the most severe type of traumatic injury to the chest that we have to deal with as nurses. The super serious or the most serious version of this is called a tension pneumothorax. So working our way up to what a tension pneumo is. So a closed pneumothorax means that an amount of air has gotten into the pleural space, but no more or no less is accumulating. That air is in there, and it just kind of, because it's higher pressure than the air inside the lung, it's just kind of collapsing it or compressing it a little bit. Then we've got our open pneumothorax. This is where there's still an open injury, and air can move in and out of that pleural space, and it still is compressing that lung. And then that leads us into the worst one, which is called a tension pneumothorax. So what this one is when there's a puncture in the chest wall, so air is moving into the thoracic cavity, but the nature of that injury is such that it's kind of a one-way valve. So every time a patient breathes in and expands their chest wall, air rushes in, but when they breathe out, that air gets stuck in their pleural space in their chest cavity. So with every breath they take, they get a little bit more pressure in their thorax. The reason this gets to be a problem is eventually there can be so much air pressure that accumulates in here that it causes the entire trachea, the heart, everything to displace from the midline over to the side of the body away from the injury. This can become a life-threatening complication. What we call these sometimes, kind of the ER term for these things, is called a sucking chest wound. So this is really, really bad. This extra tension on the heart and all the vasculature associated with the heart, so the aorta, all the carotid arteries, those kinds of things, is what we call a mediastinal shift. So it's the mediastinal, everything shifts over to one side of the body. This is bad. Tracheal deviation is one of our our hallmark symptoms of a tension pneumothorax or a sucking chest wound. Tracheal deviation is always bad. Do not ever think that tracheal deviation in a patient is an acceptable thing. Tracheal deviation means that instead of the trachea being right down the middle of their neck, it's off to the side of their neck, because all the pressure that's getting sucked into their chest wall is displacing it. It's causing that mediastinal shift to the opposite side of where the chest wound is. So if a patient ever has a tension pneumo, the thing we want to do is cover that wound with a sterile, non-porous dressing. So non-porous meaning air can't move in and out. Otherwise, there's no point. So these are things like our petroleum gauze, or things that are soaked like that don't allow air to move in or out. And then we want to tape it only on 3 sides. The reason for that is we don't want to create like a pocket underneath a fully sealed dressing. If air is going to leak out around that initial puncture wound, we want to leave one side up so that it can, if it starts to do that. So that is why we only tape the 3 sides of that dressing. Here is tracheal deviation. So most people, we look right down here at the mediastinum and we see this right here and we think 2 thumbs up, this patient's looking great. This patient is not looking great at all. So this is the thyroid in this patient. See this shading over here? This is their trachea. If you were to palpate this person's neck, this would be soft, almost like a little cavity. And over here, where it should be soft, or where their sternocleidomastoid should be, it feels like their trachea. It feels hard. So this person's trachea has shifted from the midline here all the way over to here. So it's kind of doing maybe this kind of a thing. So which side of the patient's chest is injured? So this patient has a right-sided chest injury. It's over on this side of their chest, is where the air is accumulating, causing this tracheal deviation. This is bad. If you ever see this, start calling all the friends. Call your charge nurse, call your physician, call all the friends, because this is a bad, bad thing. Here's what that looks like on X-ray. So this is a pneumothorax, this kind of dark shading in here, that's all the air accumulating in that pleural space. This is what a normal lung field should look like. So we can see the ribs through here, we can see some little like fine kind of stuff in here, that's the lung tissue. But in here, this higher density air makes it more difficult for us to see the full structure of the ribs. So this is a pneumothorax. Here's the heart right here, spine, the trachea kind of lines up with the spine, all that kind of stuff. Here's a tension pneumothorax. So we can see it's a lot darker over here, meaning that there's much more pressure. And here's the heart way over here. So instead of being kind of in the middle, kind of down here, it's pushed all the way over into that other side of the patient's thorax. So this is really, really bad. This person needs to have some decompression done. So our nursing diagnoses that we get concerned about for both pneumothorax, hemopneumo, for all of our pleural effusion type problems. One is impaired gas exchange. Anytime there's fluid or air that's accumulated in the pleura and it compresses that lung so that it can't fully ventilate, we're going to have decreased surface area where gas exchange can take place. So our patient's going to have impaired gas exchange. So their oxygen saturation, not going to be crushing it. Impaired physical mobility, partly because of the impaired gas exchange, partly because of the shortness of breath, partly because they're having like a major medical or traumatic event happening. They are not going to be moving around as effectively as they would like to or they should be. Impaired walking, same kind of thing. Also, patients who have these problems tend to end up with a chest tube drainage device, which is like, kind of think of it as a Foley catheter for the chest, except it's a little more complicated, but it works the same way. It's a gravity drain. So it's going to drain all the fluid, blood, whatever is accumulating in that pleural space by gravity. So we always have to keep those drains lower than the site of injury so that gravity can facilitate that fluid movement. Part of having that drain on there is going to make it more difficult for our patients to get around effectively. And disturbed sleep pattern, couple reasons here. One, if you can't breathe very well, you're not going to sleep very well. Two, if you got a tube sticking out of your chest, it's not going to be very comfortable to sleep. So these patients are going to have a tough time during the recovery phase of their traumatic injury. After we've diagnosed our patient from our nursing perspective, kind of the human response kind of stuff, the symptoms that we're seeing in our patient, the medical plan is very different. These are all the actual procedures that are going to be done for all of our effusion-y type problems, whether it's a liquid or an air effusion, different names for those things, but where there's a collection of stuff in the pleural sac or in the lung bag, we need to get it out. So if patients have a pneumothorax, this gets into our scariest intervention, which is our needle decompression. What we're going to do is stick a needle in like the second intercostal space, right up here in the patient's chest. You always only needle the side that's affected, so you'd never needle both sides of their chest, just the side where, so if you see tracheal deviation, if I was having tracheal deviation pushing to my patient left, so my trachea was over on the left side of my neck, we would decompress on the patient's right because that's the side of injury. That's where all the air is that's displacing all the vasculature and anatomy in the patient's thorax. But we take like a 16 gauge needle, stick that into the second intercostal space, and you keep advancing until you hear this like psss, like an air leaking out of a balloon kind of sound. That lets you know that you're in the pleura and you're starting to drain the air that's accumulated in there. It's a medical emergency. This is like one of those procedures, almost like a trach, it's like last ditch effort. We've just got to get the pressure out so the patient doesn't like die in the next 10 minutes. It's a big, big deal procedure that we do for patients. And by we, I mean, usually physicians are the ones doing this. I had to do it one time. It was like super scary, major trauma. And I had the surgeon, or not the surgeon, but the ER physician, they do minor surgery, next to me, like hip to hip with me saying, do it now. I was like, okay, doing it now. Woo. Almost like playing darts right at the second intercostal space. But you hear that whoosh and you just keep that needle in place, anchor it until it starts to slow. I didn't have to hold it for the whole time the surgeon took over, which was great because then it was like, okay, thank God, I'm off the hook now. But that's our intervention for pneumothorax, especially tension pneumothorax. It's that emergent procedure. Then there's our thoracentesis, which is that needle aspiration of the liquid contents that are accumulating in the pleural space. So all of our liquid effusions, hemothorax, transudative, exudative pleural effusions, and our empyemas. So thoracentesis, thora, meaning the thorax, centesis, meaning stick a needle in it and get some fluid out. That's a direct Greek translation, but that's exactly what we're doing. We're going to position our patient like this, kind of hunched over a bedside table so their back is nice and opened up, like the ribs are nice and spaced out. And then a surgeon or a physician is going to insert a needle and collect a fluid sample. This type of procedure is usually done as like a diagnostic procedure. So we want to get some of that fluid out, see what color it is, see what's in the fluid, to see what type of effusion the patient has. Because remember, our different colors all lead to like different etiologies of why that fluid is accumulating in the first place. Then if it's determined that we need to insert a long-term drain to get all that fluid out of the pleural space, then we're going to insert a chest tube. And these are inserted between the 5th and 7th intercostal space, kind of right in here to down here. And these are going to be, think of these like really complicated Foley catheters. They're gravity drains, just like a urinary catheter. So we're going to insert it into that pleural space, and the fluid is going to drain out. So we need to keep these collection devices, our chest tube devices, in a dependent position from our patient, meaning below the level of insertion in our patient, so gravity can facilitate that drainage. And what we're going to do with these devices is monitor both the color and the volume of fluid that's being collected. We also, it's a big deal for us to do our respiratory exams on any patient that has a chest tube in place. And this is why we teach you guys in health assessment, you always assess the same level on a patient, left to right, or right to left. But you always assess both sides before you change elevation when you're doing your respiratory exam. Because if you have patients with an effusion like this, you're going to start off at the top of their lungs, and that should sound clear. Middle of their lungs should sound the same on both sides, but the bases are going to sound very different, and you'll actually be able to hear the fluid draining on whichever affected side over time. As you see it collected in the chest tube device, you'll be able to hear lung sounds as that lung is able to fully re-expand. So we're always listening to make sure that at the bases, we're hearing equal lung sounds bilaterally. It's a big deal for our patients with a chest tube who have a pleural effusion of some type. This isn't what it looks like when a patient's getting a thoracentesis. So you can see this is a sterile procedure that the physician is doing. This is all sterile draping that's placed on the patient. So this area right in here was sterilely prepped with like chlorhexidine or iodine, depending on the patient's allergies. We've got the position patient, the patient positioned, words are hard. And what I usually do when I'm assisting these procedures is I'm standing back over here kind of face to face with the patient, and I'm going to coach them through kind of the needle insertion phase of that. Most patients who have this done, the time they have the most discomfort is actually when the surgeon or the physician is doing the anesthetizing of the skin with that local anesthetic. So I'm just back there staring them face to face, making sure they keep breathing, they don't pass out, and that we're accounting for the discomfort that we can expect with those patients. So a lot of breathing coaching, like deep breath in, out, coaching them through that procedure. So what's going on, once the needle is inserted, as you guys can see, it's a big needle. The physician is going to pull out their sample, and this sample fluid, this is like liquid gold because it is not easy to get this stuff. If we contaminate this sample or accidentally throw it away, it's not easy to get a new sample of this. It's not like a urine sample where we just get it out of the bag again. They're going to have this procedure all over again if we ruin the sample. So treat this as liquid gold. It goes into a sterile container and goes straight to the lab for analysis. This over here, so this system is a little more complex. So we've got our thoracentesis happening here, but then there's this extra tubing going to this big glass container. This is called a vacutainer. It's a vacuum sealed bottle. So then when we hook this tube up to it, it's applying suction to the patient. So we can do some volume removal while the thoracentesis is being done if we don't feel that long-term drainage is needed with a chest tube. If we think this could be just a one and done kind of procedure, then we can do this kind of deal. So for hemothorax, after the trauma has happened and patients have clotted their source of bleeding, we can do a thoracentesis, hook it up to a vacutainer, and we can just withdraw that that blood that's accumulated from the trauma, knowing that it's unlikely to reaccumulate because the patient is healed. For our transudative and exudative effusions, where there's a metabolic process or a medical problem that's causing that fluid accumulation, usually we're going to put a chest tube in because we're going to need to drain that thing over a longer period of time. So again, just to recap, we want our lungs to be normally inflated. Lots of oxygen getting in, lots of gas exchange happening. When patients have compressed lungs, that's when we've got a problem, because we need to get all of the fluid or air out of that pleural space, which is the space between the lung and the lung bag. Patients can accumulate blood, fluid, air in that space, all of which compresses that lung, decreasing the surface area where gas exchange can happen, making it really difficult for our patients to breathe and respirate appropriately. So we insert a chest tube, which looks like this, and chest tubes are about the size of your little finger, so they're big. It's not like the Thoracentesis, which is like an 18 gauge needle that goes in there. These suckers, they're not playing around. We put that in there to drain whatever fluid might be collecting in that pleural space so that we can get our patient's lung to fully re-expand and get rid of all the respiratory symptoms that they're gonna experience as a result of the medical problems of effusions or hemopneumothoraxes. Oops. So our independent interventions, the things that we wanna do independently, respiratory support is a big deal. Because our patient has decreased area where gas exchange can happen, supplemental oxygen, pretty common intervention that we're gonna apply to our patients. Also drain management, whether if they have a chest tube, making sure it stays in that dependent position, and making sure that we do strict INO monitoring of how much fluid is accumulating in that drain, and making sure that our lung assessments, that we can start to hear equal breath sounds bilaterally, especially moving into the bases of their lungs. And then vital signs monitoring, particularly for our patients with hemothoraxes or hemopneumothorax, because those are trauma-related events. We want to make sure they stay hemodynamically stable. For all of our effusions, our respiratory vitals, big deal. We always keep track of those things. Our dependent intervention, so the stuff we're looking for from other members of the healthcare team, pain management, big thing. You know, if we're sticking needles in people's chest, they're not going to be comfortable. So we need to have a plan for stratified medication options, meaning like different levels of strength of pain medications. We may want to have some like fentanyl, some fast-acting opiates if we're going to be doing one of these procedures available for our patients. But then we may want to move to like oral medications for long-term management of their pain after the procedures are done, if they have a chest tube in place long-term. And then follow-up imaging to monitor for progress. So sometimes physicians are going to order chest x-rays or do ultrasounds on these patients to visualize all the fluid that accumulated in their pleural space, to visualize it returning back to normal and the lungs re-expanding. So that's what those are going to be doing. So for chest trauma, for the implementation, one of the big things we're going to be doing is that procedural support for the thoracentesis, for the chest tube placement. These are both bedside procedures, so we do want to support that procedure. Make sure the patient is informed of what's going on. You don't want to go into one of these things blind, and educate your patient on what's going to happen, that this is going to drain that fluid out from around their lung so that they can breathe better. And then what signs and symptoms should the patient alert you to if they experience? One of the things I do with all my patients is make them an expert in what's wrong with them, because they're going to be bored hanging around in the hospital. So I'm going to give them a job, and the job I'm going to give them is to make my life a little easier. If I train them to identify the signs of the bad outcomes that could happen, they can let me know immediately when they start to see those. So if they start to have increased shortness of breath, or start to all of a sudden see leaking around the insertion site of that chest tube, let me know immediately. Activity limitations. So one, the activity or positioning around the procedure, and then the limitations afterwards. They're gonna have to take that drain with them for all activity and keep it below the level of their chest. So we need to make sure that they're ready for that, they expect it, and they're qualified to do it. And then education for safety. What can be done to prevent these recurrences? For a lot of our medical effusions, these are problems of volume status. So patients become volume overloaded and they can accumulate accumulate fluid in their pleural space. So we may need to educate them about fluid restrictions or those types of things. For our trauma patients, how to make better life choices so that these kinds of things don't happen to them again, kind of a thing. You know, they may need to go to anger management, refer them to that, so that whatever social circumstances led to this amazing presentation, they don't encounter that again, because these kinds of things, not conducive to long, healthy lifestyles. So for our evaluation, we want to see our patient, and this is for rib fractures and all our pleural things, all the accumulations of fluids. We need to see our patients return to baseline. Have they returned with their vital signs, so their respiratory rate and their oxygen demand, not necessarily their saturation, but are they back to room air or whatever baseline level of oxygen they were getting before this injury? And are they medically stable and safe for home? That means hemodynamically. Have we accounted for their ABCs? Have we accounted for what's it called? The blood pressure, heart rate thing. Hemodynamic stability, that's the one. What else? First and foremost, don't be that guy. We don't stick our fingers in patients' chests. Like, that's creepy. That's really weird. This is what it looks like when a chest tube is being inserted and the surgeon actually does stick their finger in there just to make sure that the wound stays open. That's where the chest tube is going to go. But as nurses, like, don't stick your finger in somebody's chest. It's creepy, it's weird. Your friends are going to look at you funny if you do that to people. So don't do that. That's it for chest trauma. Let me know if you guys have any questions about this content.